Welcome to Real Talk in Medicine, a podcast production of UT Physicians. My name is Shelley Vanker. Joining us today is Dr. Amanda Jagolino-Cole, a vascular neurologist here at UT Physicians. Thank you so much for joining us.
Thank you for having me.
Okay, so talk to us about what is vascular neurology. I want to start there.
Sure. So stroke is when there's a blood clot in the brain, and the area that is fed by that blood gets cut off, and it can cause death, disability, unfortunately. So a vascular neurologist is trained in neurology, but also has some special training in how to manage stroke, both in the acute setting when the patient first gets to the hospital, as well as in prevention setting, recovery settings. They're just really comfortable managing stroke.
You are the subspecialty of neurology.
Yes, one of the subspecialties, yeah.
Very good, yeah, very important. And you are on our teleneurology team. I don't think a whole lot of people at UT Physicians or abroad know that we have a teleneurology team. It's very exciting to learn about, but you guys are not new. You have been here for quite a while and operating. Talk to us about the history.
Certainly. Well, our program started in 2003. There has been telestroke, teleneurology since like the late 1990s, but we started in 2003. So long before the COVID pandemic, and we provide care for patients who reside in neurologically underserved settings, where we can beam into their cameras that are there. They have these devices where we can beam in, and using telemedicine, using internet, and using our desktops or laptops, we can take care of patients that way. And that's very important because stroke can be very time sensitive. The longer we wait in stroke care, we can incur more death and disability. So the faster we can get to the patient, the better. And so that's very helpful for us to beam into these places. And so we have a team of about 15 neurologists. All of them are board certified. All of them have some subspecialty training, whether that's in stroke or in neurophysiology. They also all take care of patients in person. So they don't lose sight of what that is like to be on the other side of the camera. So we kind of have that balance. So
that's great. I want to back up because you used the word beam, and I think a lot of people are thinking Star Trek.
Yes.
So talk to us about the technology that goes into being telehealth specifically for vascular neurology.
Certainly. So the sites that we collaborate with, they have a device that sometimes we refer to as a robot. Sometimes they name the robot. And we are able to, there's a screen on the robot, and we're able to beam in so that the patients and the providers at that site can see our faces. We can show things on the screen. And so we can have a conversation with them. And then they're able to see us, we're able to see them. So, we're able to have a conversation, we're able to do a neuro exam, we're able to get the critical information needed to make, emergency decisions. There are some barriers with it. It is, we're geographically far away from each other. So, it takes a team to make that work, to be able to make sure everyone is comfortable with the camera, that we have all the information we need to make decisions.
Mm-hmm. I love what you said about you have your neurologists that are also patient-facing still, so you don't lose that touch. It's got to be very interesting to be a patient, and then they say, hey, your vascular neurologist is just on the line. This is telehealth before telehealth really was as popular or well-known as it is today. I think that's remarkable that you guys have been doing this for more than 20 years.
Yes. And I've been here for a little over 10 of those, and it's just been a great experience working with these sites and with our team. So
yeah. And so talk to us. Okay, I want to go more into this robot. The patient can see you from their side of it, and you're able to really assess them and evaluate them virtually.
Yes, exactly. So we're able to do a neuro exam. You can ask the patient to talk to us. We can ask them questions to see if they understand us. We can do the motor exam, which is asking them to lift their arms. If they're not as responsive, we can ask the nurse on the other side or the APP or the physician to help us with the exam and lift the arm up. So we're able to get a very good exam and good enough to make emergent decisions.
And talk to us about why this is so important, why we have teleneurology at all.
Right. So unfortunately, there's a shortage of neurologists, and that's been for probably forever, but especially since there were more and more therapies that we can provide for seizures, for stroke in the inpatient setting. There's just been a divide in terms of how much coverage we can provide. And so we are able to increase access. So if you take a map of Texas and you map out the community members who are within an hour from a primary stroke center, and then you add telemedicine to that, you can see that it increases significantly the number of people who have access to a primary stroke center with the telemedicine. So it's really important. Neurologically underserved can be rural, and as we know, there's a fair amount of rural area in Texas. It can also just be areas where there's 2, 1, maybe even 0 neurologists. And so we're really supplementing coverage where we need to. We're providing all the coverage where we need to in order to make sure these patients get timely care.
It's incredible. So you guys are working through UTHealth, through UT Physicians as a program, but being beamed into other hospitals, not very close to Houston. Beaumont, Victoria, Matagorda is one of the locations, correct? And those are areas where they just don't even have a vascular neurologist. They don't have access to a vascular neurologist.
Exactly, yeah. So there's not someone on call to, and it's a 24/7 job, right? So a stroke can happen, unfortunately, any time of day, any time of night, and it is still time sensitive. So it's important for us to be able to beam in at any hour or any minute, actually. So.
And we talk about this being a service, but this is also a partnership, right, with that medical staff in those hospitals and those communities. Talk to me about that relationship.
Yeah, it's amazing. It's probably one of my favorite parts. These sites, they're really, limited resources. Not everyone has, the resources that we have in the Comprehensive Stroke Center. So limited resources, but the people are just amazing. We work with a site where one of the ER doctors also covers clinic, even though he's always on call in the ER too. We work at a site where the stroke coordinator is also the emergency cardiac coordinator, the emergency trauma coordinator. So these people are wearing several different hats, and it's really just inspiring to see that daily. And we feel, okay, if they can put that much into taking care of their patients in their community, we should be, doing that as well. So our goal is really to provide as quality in-person care as we do on the camera. And so that's one of the reasons we do like that our neurologists also provide care in person. And that is not always easy to do given the barriers that we've discussed. So.
Yeah. And you guys do get opportunities to go visit. So you have developed relationships in person, not just by beaming in.
Yeah. So we'll go just to visit and have a meeting. We'll go to our collaborating sites. We'll go to provide education, first responder education, clinician education, stroke support groups, whatever is needed. We really want to be an indispensable resource for these sites.
Yeah, truly remarkable. And I know I've said that already. But I'm just geeking out over this teleneurology program we've had for more than 20 years when truly people didn't really know about telehealth. It wasn't very popular or available to the masses until the pandemic.
Yeah.
And you guys were doing this well before that.
Yes.
And so I want to talk about the vital importance of and timeliness of your treatment, specifically with stroke.
Yeah.
Because that's the biggest service you provide, correct?
Yes. So we provide a couple different services. So one of the kind of, as you put it, more vital or time sensitive is the neuroemergency care. So that can be stroke, that can be like status epilepticus, there are neuromuscular disorders where patients can have trouble breathing or become diffusely weak all over. So that's one of the services we provide is that emergent care. And again, those are all time sensitive issues. We also provide care where we follow up in the hospital after the patient's been admitted, and we decided on the emergent issues regarding their stroke. So how do we, what caused the stroke? How can we prevent another stroke? So we do some follow-up care as well in the hospitals.
And what would happen if we did not have this program, this teleneurology program for these hospitals?
Right. So, we could do the time sensitivity. The patients might not have received as much care. We know that historically and in the literature that once telemedicine is instituted, or telestroke specifically, that the number of patients who get treated appropriately with thrombolytic or the clot-busting medication goes up, and that quality metrics are better in terms of timeliness of care, as we call it, the door-to-needle time, as soon as the patient gets to the hospital and as soon as they get the medication IV, the door-to-needle time is really important. So we help with the quality metrics, we help with the clinical care. If there's ever any research or quality questions, we're available for them. We have the community outreach as needed, and so there's a lot of things we provide with our services and with our collaborating sites.
So it sounds like without our program, without this outreach, there would be a delay in treatment, right? And a delay in treatment could that be fatal with a stroke case?
Yes. Yeah. So unfortunately, stroke is one of the leading causes of death and disability. And so we help significantly in that sense.
So you're truly saving lives from a laptop in Houston for somebody in Matagorda, somebody who ends up in the hospital in Victoria.
Definitely. So, but it's not just us. We're working with these sites. So it's the ER doctors that we work with, the nurses that we work with, the advanced practitioners. We do it together. So
let's talk about the challenges of teleneurology. I guess first with even having access to the bandwidth that you would need to beam in, right? And then the technology needed to keep you guys up to date with able to zoom in and see them and talk to them.
It definitely, it can be very hard to communicate. You can FaceTime your friends and family, but it's different when you're providing medical care over the camera. So you again want to provide as quality care as you can in person over the camera. So you're really trying to establish rapport with the patients, with their families. You're trying to establish rapport with the medical teams that you're collaborating with. It can be weird to have the camera. Again, we're more and more used to it after telemedicine, after the pandemic, but it still can be a little bit jarring, especially if someone's having an emergency, and it can be really scary. So a lot of what we train our students, our fellows, our residents is, establish rapport, gain that trust that you gain when you're in person, gain that same trust over the camera. And then you will be able to, the patient will trust you and be able to take care of them as much as you need to. So
I can imagine them going through this health crisis and not understanding why is my doctor on a laptop or through this robot equipment, and asking a lot of questions about how you can even care for me.
Yes, certainly. And so a lot of it is just, letting them know who we are, why we're doing this over the camera. We'd love to be in person if we could, but unfortunately we're not able to. So
just not enough of you.
Exactly.
We need to divide you out.
Exactly. Yes.
Copy paste.
Yeah.
Okay, so let's talk about the making telemedicine like this more equitable.
Yeah.
And the importance of that and what that really means.
Sure, certainly. So, telemedicine does help some equity issues, so especially with access. But at the same time, because of broadband, internet connection, technology costs, it can be a barrier as well, and also because of that kind of personal barrier. So one of the ways to provide more equitable telemedicine is education, and that's something that's very dear to us. Making sure that our clinicians are comfortable, are familiar, but also know how to reach that patient. And so one of the ways is having, we have a telemedicine elective for our medical students. We have residents and fellows who rotate in telemedicine, and that way they're more familiar and ready when they're in independent practice to be able to take care of patients over the camera. So
when you were going through medical school and through your fellowship, did you ever envision yourself being a telemedicine vascular neurologist?
No. I actually just fell in love with telemedicine during fellowship, so I didn't have any exposure during medical school. It wasn't even a thing on my radar. I saw, one case with one of my senior neurologists, my attending neurologist. I knew he was seeing patients on the camera. I didn't really understand it much, but I was able to, as a stroke fellow here, rotate in telestroke, and that's just where I really enjoyed. I just fell in love with working with the sites, with the patients, with the families, with the nurses, any first responders who are available on the camera, the ER doctors, just really making that relationship and forming that bond with them was really exciting for me. So that's kind of how I got into it. So.
Yeah. So it was that experience in the rotations that you got before. Okay. Mm-hmm. Yeah. Definitely. Okay, so talk to us about why our program is unique.
Oh, sure. So, as we know, Texas is largely rural, and there's a lot of underserved areas, medically underserved or even neurologically underserved. So, we are different in the sense that, all of our providers are in Texas. We know who we're transferring to, where we're transferring to, if we need to transfer a patient for a higher level of care, like a neurosurgery procedure or a clot removal or thrombectomy. So we know who we're transferring to if we need to, but we also know where we're keeping the patient if they're going to stay locally. We want the patients to stay local if they can, because then they're closer to home, their families can visit them, the transportation costs go down significantly. So, we see both sides of it. So I think that's one thing that's unique. We're very familiar, and again, we have formed a personal relationship. We really see each site kind of has its own personality, and getting to know that personality and working with them on a day-to-day basis, I think makes us unique as well.
So you are Texan doctors taking care of Texans.
Yes.
And that is unique because there are so many telehealth programs out there that are the nurse or the practitioner on the line with you is from a different state, different time zone even.
Right. Yeah. And I think that works in the sense that then those patients get covered, but I think it just adds a little bit of more of a personal touch. And it's so easy to lose sight of that personal touch when you're on the camera, but we're able to maintain it for those reasons.
Yeah. If it kind of still feels like you're still a doctor in my area, again, building that trust that you said is even more difficult to build when it's over a screen. Yeah.
Certainly.
All righty. And then you mentioned why you fell in love with this particular niche. Are there any stories that really stand out to you over your career doing vascular neurology telemedicine?
Sure. So there's a couple. There is a case we had. One of our providers took care of a patient who was 90-something years old, and this was a few years ago. And, oftentimes patients who are older, there's not as much certainty about giving thrombolysis or clot-busting medications or some of the acute care that we provide over teleneurology. But this patient received the clot-busting medication. And the next day, she was complaining about her lunch. And it was so cool to see that because she wasn't talking the day before. She was not moving one side. And then she was in the hospital thriving. So that was really cool. And I think one of my favorite times or things that happen in this role, we have a stroke support group. And it's really cool when a stroke survivor comes up to me and says, "Hey, I saw you," or "I saw, one of my colleagues on the camera, and this patient is walking and talking," or this stroke survivor is walking and talking and telling me this, and they just, they're grateful. They say, "Thank you for the care that you provided." That just means the world to us. So
the care you provided from many, many miles away.
Yes.
You're saving lives. They come to the stroke support group to thank you.
Yes, and that's just, there's nothing more rewarding than that in this job. So
that's truly beautiful.
Thank you.
And so do you hope that telemedicine is something that can expand to other subspecialties?
It does, and I think every specialty kind of uses it differently, and it just depends on what that in-person care looks like and how you translate that as well as you can over the camera. So, and even in telestroke, we are learning more about how to provide ambulatory telestroke, so how to take care of patients in the clinic, how to provide rehabilitation, physical therapy, occupational therapy. What are the best ways that we can utilize this tool to reach these patients? Again, it'd be great if they could just come to, Houston, Greater Houston, and get therapy or rehab or whatever, but it's not always possible. So we're learning more and more about how to utilize telemedicine, even in stroke, but also in other specialties as well.
That kind of leads into the next question, which is, what do you see on the horizon for telemedicine?
I think it's more of just leveraging the tool. I think we had to use it very emergently during the pandemic, unfortunately, and we just did it because we had to. But I think we're learning more about how to make it more equitable, how to make it higher quality, what settings to use that versus in person versus some sort of hybrid model. Also, how to use it in not just telemedicine, but also telehealth and therapy and other ways to utilize the technologies to reach patients.
Okay, so let's talk about what causes a stroke and what are the risk factors you should be looking for.
Certainly. So there are different causes. So some causes of stroke are what we call a small vessel or large vessel disease. So you have an artery, the artery is like a pipe, and if you have plaque buildup, that can cause a stroke, and the risk factors for that include high blood pressure, diabetes, high cholesterol, smoking. So there are risk factors that some of them are things that we have control over with either medical management or, quitting some toxic habits. Some we don't have control over. Sometimes there are more predispositions for a certain gender or age, or and then there's other causes that could be cardioembolic, so meaning that something in the heart has caused a stroke. Maybe a clot has formed in the heart, whether that's with something called atrial fibrillation, where the heart kind of quivers a little bit, the clots kind of form in the heart, and then they can shoot up to the brain and cause a stroke. And also, if the heart's weak, so heart failure can cause stroke by clots forming in the heart because it's not pumping as well. And unfortunately, these are very common risk factors that we see a lot, not even just in the stroke world. They, the same risk factors for heart attacks and peripheral vascular disease, clots in the arteries in the legs and arms. So these are very pervasive risk factors, unfortunately.
So if you're going through something and you don't know what it is, right? You're at home, you're at work, you're doing something. What are the signs? What are stroke has an acronym, right?
Yes.
To look for what is the cause. Okay.
Yeah. That acronym is Be Fast. So that's balance. So if you're feeling imbalance, walking imbalance, feeling kind of dizzy, like room is spinning. E is for eyes, so vision issues. F is for face, so patients with stroke can have a facial droop. A is for arm, so, is the arm weaker than normal? S is for speech, so if there's any garbled speech, as some people call it, or trouble understanding or trouble getting the words out, the speech is not making sense. And then T from Be Fast stands for timeliness, so making sure you call 911 right away. It is very time sensitive. Again, the longer we wait with a stroke, then we're more likely to have death and disability, unfortunately. So,
and when we talk about those symptoms, the vision, the face, the arm, is that only on one side, or could all of that be on both sides?
I would say if anything happens even on both sides, to get it checked out emergently, especially if someone's having trouble walking or doing their daily activities. Usually in a stroke, it's one side, but not always. So just make sure for patients who have these experiences, they should really make sure to call 911 and get seen immediately. So.
Okay. And sorry, just not to belabor the point, but if there are symptoms on one side, are all of the symptoms on the same one side?
They can be on the same side. We can also have what we call cross signs, where maybe there's weakness in the face, but because of the way that the neurons connect through the brain and through the brainstem and the spinal cord, the weakness can be on the other side as well sometimes. So it can be crossed signs, as we call that. So.
Okay, so it's important to really know this acronym.
Yes.
Be fast.
Be fast. Yep, definitely.
So let's talk about when we say that you guys serve areas or hospitals that are deficient of vascular neurologists. That's not any sort of put down for those particular areas, right? They still have excellent health care. Mm-hmm. Talk to me about that stigma that these rural hospitals get because they may not have a subspecialist.
Right, yeah. So as a comprehensive center, we do get a lot of patients transferred into us from other sites. And, I think there's sometimes a stigma like, why didn't they do this test or why didn't they do that test? But, the issue may be that they just didn't have that test. Some of our sites don't even have MRI every day. So, it's easy for us to be like, why didn't they do this or that? And, I think it's important. One of the reasons I think it's important for students and postgraduate trainees to get exposure to telemedicine is to understand that there's different resources in different areas. Obviously, it'd be awesome if every single hospital had all the resources possible, but it's just not a thing. And so it's really important for us to understand, they're doing the best they can too.
And you've seen that up here. I mean, you go there, you've seen them wearing all the hats.
Yes. All the hats, yes.
To try to make sure that their community is covered.
Yeah. It's really, again, really inspiring to see them and see how hard they work for their patients. And in a setting of limited resources, usually when we're training in a training program, we are in an area that, a facility that has all of the studies and all of the specialists. And so, it is eye-opening and important for us to remember that these hospitals are just doing the best they can with what they have. So.
Exactly. And then what does it take to maintain this type of collaboration with a hospital that you don't get to visit in person very often?
Mm-hmm. Mm-hmm. Yeah, I think it's important to try to visit in person because there's just something, it's just human nature, sort of breaking bread or, just sort of getting to know each other in that sense. The majority of our meetings are virtual, and it's nice to have that option. But we do try to make sure we are checking in with the collaborating hospitals in person. It also helps us because then I can see, this is what the ER is like that I'm rolling around in, on the camera. And so it's cool to see, and meet the clinicians in person, like, the people you see on the camera. It's like, I know you. It's, it's like we've known each other for years. And, so we just hadn't seen each other in person yet. So that I think is helpful. And, we also have an open door if any site ever, if anyone's ever wanting, in the area and wanting to visit and see what it's like on our side of things. We are always welcome for that. I'm a big fan of shared leadership. That's kind of how I was trained in many ways. So I think it's important for us to kind of think about the needs of the group, and not just they need this and we need this, but like, we have a common goal. How are we going to share our resources and, share our ideas to provide the best care possible for these patients? So it's a lot of shared leadership, a lot of checking in, a lot of just, again, having that open door policy, just sort of like if you have a question about a patient, just let us know. If you have a question about, a new metric or a new medication, we're a resource for you.
So even though you may only mainly see these other providers and nurses and healthcare employees virtually every week, you've built this relationship with them over years.
Definitely.
And you know these hospitals.
Yes,
You know how they run.
Yes.
You know the patient population.
Yeah. And that's the other thing I like about working with the community members as well is because every site has their own personality. Every community has its own personality. So it's really cool to see that.
So wonderful. And I love hearing this story of how you guys are filling this gap in a very crucial healthcare setting. So thank you so much. Thank you for joining us, Dr. Jagolino-Cole. It was so great to talk to you. And thank you for joining us on this edition of Real Talk in Medicine, a podcast production of UT Physicians.